Hello and welcome to my YouTube channel. Continuing our series of surgical emergencies, which we have been covering in the past, today we'll be covering one more very important topic, both clinically and from examination point of view, and that is a patient with intestinal obstruction. We would be discussing in great detail about the etiology, the pathophysiology, and the management of intestinal obstruction. I would expect this lecturate series to be very useful for PG residents who are appearing for their surgery examinations, as well as MBBS students who are doing their surgery rotation. So, without wasting further time, let's get started. We would be covering this very important topic under the following heads. First, we'll go on to define what exactly is intestinal obstruction. We will go also to see what are the different ways in which we can classify intestinal obstruction. Etiology and pathophysiology are very important to understand this concept of managing a case of intestinal obstruction. We would also discuss in great detail about the clinical features, the investigations and their rationale and how to interpret them in a case of intestinal obstruction. And finally, a word about management and complications and long-term outcomes of a patient of intestinal obstruction. Now, what exactly is intestinal obstruction? The name itself is quite clear. That means there is a blockage which prevents the passage of contents from the proximal bowel to the distal bowel across the obstruction. Now, this obstruction could be a mechanical obstruction. That means there are certain mechanical pathogenetic factors or some lesions which prevents this passage from proximal to distal across the obstruction, or it could be just a functional blockage. That means there may be some functional element and there may not necessarily be some mechanical factor which leads to obstruction. Now, this obstruction in the lumen or in the wall of the bowel constitutes a surgical emergency, and it has significant morbidity and mortality if it is not treated properly and within a specified time frame. If you see the incidence of this condition world over, it would constitute approximately 15 to 20% of all surgical admissions coming to the emergency department or in the acute surgical ward and ICU settings. So that means it does form a significant major chunk of surgical emergencies, which as a surgical resident, a house officer, or even an MBBS student doing their emergency call duties would come across to see. And that's why it is very important to understand what is the basic management and other complications of this important condition. Now, as I have already told you, it causes significant mortality also. It can go up to 25% if the intestinal obstruction becomes complicated with strangulation. Otherwise, for simple obstruction without any complications, the mortality ranges in the range of 2 to 8%. Just some key facts about intestinal obstruction. The small bowel obstruction constitutes almost 80% of cases of intestinal obstruction, as compared to a large bowel obstruction, which causes only 20% of the remaining cases. So, small bowel obstruction is by and large the more common variant of intestinal obstruction than a large gut obstruction. Number one cause of small bowel obstruction world over remains and will be post-op adhesions. Now, these adhesions usually are post-operative, but it can also occur as a features of congenital bands and congenital adhesions. Together, these adhesions constitute almost 60 to 75% of cases of small bowel obstruction. Whereas a large bowel obstruction, which is significantly less as compared to small bowel obstruction, the number one cause of large bowel obstruction is colorectal carcinoma. Now, here adhesions also play a very important role in its etiology, but colorectal carcinoma and other pathologies take slight precedence over adhesions. The peak age of intestinal obstruction is elderly population. So it mainly affects elderly population beyond the age of 60 years. However, it can occur even in younger age group, and no age is exempt from getting this intestinal obstruction. Now, let's go on to discuss about the classification and different ways in which, because the classification would help us in simplifying and understanding this complex topic much better. Now, there are different ways of classifying a patient with intestinal obstruction depending on by mechanism, that means what caused it. It could also be classified according to by segment, also by vascularity and by degree of obstruction. So let's go into one by one in slightly more detail. By mechanism, we have already seen that if you see what causes intestinal obstruction, what are the different mechanisms leading to intestinal obstruction, then broadly we can divide it into a mechanical and functional. The mechanical is because there is a physical obstruction of the lumen or the wall of the gut, and this physical obstruction could be intraluminal, it could be mural, that means within the gut wall, or it could be extramural, that means it could be outside the bowel wall. So, this is a classically a mechanical obstruction which is fairly commonly seen as compared to the other variant, which is a functional obstruction, which we also call paralytic ileus. Now, here there are no physical element of physical obstruction present as compared to like mechanical obstruction. But here the main concept or main problem or the main pathology is the failure of peristalsis. And this failure of peristalsis may occur because of the ganglion cell paralysis, which can occur in different setting, the most common being postoperative, patient with severe sepsis, or even certain metabolic disorders like hypokalemia. Okay, so in such cases, there are so many causes of this functional obstruction, and this would also lead to a typical case of intestinal obstruction. So this classification is by mechanism. Then we go on to discuss about the segment of the gut which is involved in intestinal obstruction. And here we have already seen that classically we have a small bowel obstruction and a large bowel obstruction. Small bowel obstruction most commonly occurs in jejunum and ileum. Together, this site would constitute more than 80% of cases of small bowel obstruction. Whereas a large bowel obstruction can occur in colon, specifically in the descending colon and sigmoid colon and rectum. And together, this we have already seen constitutes almost 20% of cases of overall cases of intestinal obstruction. We can also classify intestinal obstruction based on whether it gets complicated or it's a case of simple intestinal obstruction. Now, complication means whether the vascularity is compromised or not, because the end result of untreated intestinal obstruction would ultimately lead to a compromised vascular supply to the bowel, leading to ischemic necrosis. So, based on that, we have a simple obstruction where there is no vascular compromise and it's just a case of intestinal obstruction. Here, the vascularity remains patent, and these cases are reversible. That means once you treat the underlying cause of intestinal obstruction, the patient can recover very quickly without any sequelae, morbidity, and mortality. On the other hand, we have a strangulated obstruction where obviously the blood supply is compromised, leading to ischemia of bowel wall, and this can also lead to perforation of the gut. Now, this is a surgical emergency. And because we have already seen that if there's a strangulation, the mortality can go right up to 25%. So this is another way of classifying depending on whether it's complicated by diminished vascular supply or not. And lastly, we can also classify intestinal obstruction based on degree of obstruction. That means how much of lumen is obstructed, whether it is a complete obstruction where there is complete blockage of the intestinal lumen leading to failure of passage of the contents distally across the obstruction. So there would not be any passage of stools or even gas distally across the obstruction. So this is a complete obstruction, and needless to say, because it is complete, it presents dramatically, and it also is a surgical emergency because here the rate of complications increases exponentially as compared to a partial obstruction, and patient can quickly go into ischemic necrosis of the bowel if left untreated. Whereas we also have a partial obstruction where the lumen is obstructed but partially. That means some amount of feces and flatus can pass distally across the obstruction. So it's an incomplete blockage, and these patients with incomplete obstruction or partial obstruction may not present so dramatically, but very important is that they can also recover with a trial of conservative management, which is not possible in case of a complete obstruction. So this in nutshell is how to classify intestinal obstruction. Now we'll come one by one into the etiology of small bowel obstruction. That means what causes it, etiology of large bowel obstruction, and then also cover about some special situations. The first and foremost is etiology. If you divide into intraluminal, that means the causes are within the lumen, then mural or within the wall, and extramural, that means outside the wall. So coming to intraluminal, the most important cause of intraluminal intestinal obstruction is, there are variety of causes, but we'll go on to few important ones, and the most important ones are foreign bodies. Now, in the foreign body, we have bezoars. Bezoars are nothing but the foreign bodies which basically go and obstruct the small bowel, specifically the stomach, duodenum, and jejunum and ileum. Now, these bezoars can be trichobezoars, that means clumps of hair which are ingested by the patient, especially the patients who are in psychiatric institutions. They are more prone for such type of episodes. And this clumps of hair which have been ingested by the patient over a period of time leads to a small bowel obstruction. That is trichobezoar. And phytobezoar is when the patient ingests undigested cellulose products, plant based products like leaves and seeds and other barks, tree barks, again seen in patients who are in the habit of picking up these items. Specifically, again, is seen in psychiatric institutions, and this can also cause small bowel obstruction. So, these are the two type of bezoars, the phyto and the trichobezoar. Then we have another very important cause, and that is gallstone ileus. Though the word here is ileus, in effect, it is not a functional obstruction, but it is more of a mechanical obstruction by a large gallstone. Now the question arises: how do the gallstone reaches into the small bowel? Now this large gallstone, which ideally should be more than 4 centimeter in diameter, if it is situated in the neck of the gallbladder, this causes an infundibulum. And within that infundibulum, because of this large size, over a period of time, there is a pressure necrosis of the wall of the gallbladder. And whenever there is a pressure necrosis, this may cause perforation of the gallbladder infundibulum, where the stone is situated in the neck. And it may cause a fistulous communication to the adjacent lying bowel. In that case, it would be a duodenum. So, in that case, we have a fistula, which is a cholecysto-enteric fistula, because of the pressure necrosis of this large stone situated in the neck of gallbladder. And through this fistula, this large stone can enter into the small bowel and goes and lodges in the most narrowest part of the small bowel, which is about 10 to 20 feet of the ileocecal valve. And this part is the narrowest part where it can go and lodge and can cause intestinal obstruction. And the patients would have typical features of intestinal obstruction, that means vomiting, constipation, and abdominal distension. These patients would also, when you do an ultrasound, and you can see the presence of gallstone in the terminal part of the ileum. And thirdly, because there is a cholecystoenteric fistula, the air may enter into the biliary tree from the bowel. So, these three classical symptoms and signs: number one, presence of small bowel obstruction; number two, demonstration of a gallstone by ultrasound in the terminal part of the ileum; and number three, presence of air in the biliary tree, what we call pneumobilia. These three symptoms and signs together are known as Rigler's triad or Rigler's criteria, which constitutes gallstone ileus. We also have foreign bodies which can cause small bowel obstruction. Intussusception, especially in children, where there is a telescoping of a proximal bowel distally, can also lead to intestinal obstruction. In neonates, Meconium plug syndrome and impacted meconium is quite a common cause in some neonates with congenital abnormalities. Fecal impaction in a patients with chronic constipation, especially patients who are bedridden, patients who are in sepsis, patients who are having cerebrovascular accidents. They can have fecal impaction because of chronic constipation, and this classically leads to large bowel obstruction. And we also have, coming to the mural causes, that means within the wall, one of the commonest wall cause or mural cause is colorectal carcinoma. Similarly, diverticular disease leading to thickening of the musculature of the bowel wall and leading to narrowing of the lumen is another very common cause of the mural cause of intestinal obstruction. Then we have radiation enteritis, inflammatory bowel disease leading to different type of strictures like Crohn's disease specifically. Similarly, congenital atresia, where there's a failure of recanalization of the lumen. These are or ischemic strictures. These are the important causes which can lead to mural causes of intestinal obstruction. And then we come to extramural. That means the causes lie outside the bowel wall. And here we have already seen the post-surgical adhesions, which is the commonest cause of intestinal obstruction in 60 to 70% of cases, would be the most common cause of extramural intestinal obstruction. Hernias, specifically the inguinal hernia, the femoral hernias and paraumbilical hernias, volvulus, more commonly seen in sigmoid, less commonly in cecum. Any compression of the bowel wall by extrinsic mass like a tumor or a lymph node mass, any abscesses, abscess cavity or a phlegmon, endometriosis, a gynecological condition. These all are important causes of extramural intestinal obstruction. Now, this is a percentage wise, especially in small bowel obstruction etiology. We have already seen this fact that adhesions together accounts for about 65% of cases. Hernias would account for about 15%, inguinal, paraumbilical, and congenital inguinal hernias, as well as femoral hernia to a lesser extent. Malignancies are not so common in small bowel obstruction, but they also account for about 10%. Inflammatory bowel disease, specifically Crohn's disease, is another which can lead to benign strictures, which can also cause small bowel obstruction. And others like volvulus and other causes together constitute about 3 to 5%. Adhesions are most common, we have already seen. And if you do a formal laparotomy, that means open laparotomy as compared to laparoscopy, the incidence of adhesions in open surgery is much more than in laparoscopy, which we'll see later on. Hernias, inguinal hernias specifically, and in children, congenital hernias are notorious for causing intestinal obstruction. Femoral hernia, because the content passes through a narrow femoral canal, has the highest strangulation risk. Crohn's disease, an inflammatory bowel disease, causes recurrent partial obstruction from inflammation, recurrent inflammation, and stricture formation. Intussusception is quite common in children as a cause of small bowel obstruction. If it occurs in adults, always the leading point which leads to telescoping of the gut from proximal to distal part is always a starting point, is always more commonly a tumor. Whereas in children, the starting point is could be a inflamed submucosal lymphoid follicles, or it could be a polyp. Gallstone ileus, we have already seen the Wriggler's triad is the one which would help you in diagnosing a patient with a gallstone ileus. Coming to large bowel obstruction, incidence wise, we would see that colorectal carcinoma accounts for almost more than 50% of cases. About 55% would be due to colorectal carcinoma. Volvulus, especially the sigmoid volvulus, do play a very important, significant proportion of cases. About 15% of cases of large bowel obstruction would be accounted for by sigmoid volvulus. Diverticular disease is seen in about 10 to 12% of cases and is also one of the commonest cause of large bowel obstruction. Cecal volvulus is not so common as sigmoid volvulus. However, it would account for about 7 to 8% of cases. Intestinal pseudo obstruction, also known as Ogilvie's syndrome, is, as the name suggests, there is no mechanical obstruction, but here there is a massive dilatation of the bowel, specifically of the transverse colon, commonly seen in patients who are in sepsis, who have undergone a very extensive laparotomy, patients who are nutritionally depleted, patients who have certain metabolic disorders like uncontrolled diabetes, or even in patients who are bedridden or patients who are not ambulant. In such a cases, this functional intestinal obstruction, also known as Ogilvie syndrome, can lead to perforation of bowel, and the underlying cause should be treated to prevent further complications. And other causes of intestinal obstruction would account for another 3 to 5%. Just for key points in large bowel obstruction, colorectal carcinoma is most common if you see the obstruction left side of colon as compared to right side. Typically, that apple core appearance on imaging would be seen in colorectal carcinoma. Sigmoid volvulus is commonly seen in elderly institutionalized people who have a sigmoid colon which is loaded with stools in a patient who has got chronic constipation. Classically, the coffee bean sign, which we will see later, would be seen on imaging. Cecal volvulus is more common in younger patients as compared to sigmoid volvulus, which is more common in elderly patients. Ogilvie syndrome, we have already seen, is a functional cause. Treat the cause and also give neostigmine. And sometimes a competent ileocecal valve on one end and a complete obstruction of the large bowel towards the descending colon on the other end would lead to what is known as closed loop obstruction, leading to significant risk of perforation of the bowel wall. So this is a classical apple core appearance which is seen on imaging in a patient of colorectal carcinoma. Now, coming to etiology about adhesions, what exactly leads to adhesions? There is initially a peritoneal injury, which could occur because of surgery. It could also occur because of any radiation or ischemic damage or even infection. Whenever there is a peritoneal injury, there is a mesothelial damage, the cellular damage, which would lead to exudation of fibrin, which gets deposited onto the serosal surface. So, peritoneal injury ultimately, the end result is a mesothelial injury, which leads to outpouring of fibrin, which gets deposited on the serosal surface. Now, once it gets deposited on the serosal surface, this fibrin forms fibrin bridges, which connects the adjacent loops of bowel or the bowel to the parietal peritoneum. This fibrin bridges connects the bowel to bowel or bowel to overlying parietal peritoneum. So this over a period of time can get fibrosed, and this what we call as a mature adhesion once it gets fibrosed, and then it becomes a dense fibrous band which may kink or even compress or even trap a part of the or segment of the bowel. There is also a fibrinolysis failure seen in such cases, and this would lead to persistent fibrin, which ultimately leads to fibroblast growth and collagen deposition. So, all these factors, the inciting event is a peritoneal injury and mesothelial injury. So all this would lead to development of thick adhesions over a period of time, which can cause intestinal obstruction. What are the risk factors and how do you prevent this post-op adhesions? Because they form so important cause of intestinal obstruction. The risk factors are any lower abdominal or pelvic surgery, especially the gynecological, the colorectal surgeries, are at more risk of adhesions than other causes. But however, this is not a rule, but the adhesions can occur in any type of surgery. It can occur even in non-trivial surgery like tubectomy or even appendectomies. Multiple surgeries or multiple prior operations is also one of the important risk factor in a patient who has undergone multiple prior surgeries. You can expect development of adhesions in such a patient. Any intra-abdominal infection or peritonitis would increase the chance of post-op adhesions. Similarly, any ischemic damage occurring during the surgery would also increase the chance of post-op adhesions. If the handling of the bowel during surgery is not delicate and it is causing too much of trauma to the bowel wall, then it can also damage the serosal surface and can lead to post-op adhesion. So a very gentle handling of the gut is essential prerequisite to prevent post-op adhesions. How do you prevent it? As far as possible, a laparoscopic approach would be better than an open surgery, because we have already seen that laparoscopic surgery has lower incidence of post-op adhesions as compared to open surgery. Minimize serosal handling. Delicate bowel wall handling is one of the key factors in preventing post-op adhesions. There are certain anti-adhesion barriers also, like Sepra film, which can be used to prevent a patient, especially in a patient who has high risk factors for development of post-op adhesions. This is a classical adhesion which can be seen between the two segments of the bowel. Now, this still initially is a fibrinous bridge. Over a period of time, it can become a dense fibrotic band. Hernias and volvulus do play a very important role in intestinal obstruction. Hernia related obstructions, if you see, inguinal hernias are one of the more common, and in the inguinal hernias, indirect hernias are more prone for intestinal obstruction because the contents has to pass through the inguinal canal, which is quite narrow. Similarly, femoral hernias also are at risk of strangulation because of narrow neck and passage through the femoral canal. Incisional hernias post-operatively can cause intestinal obstruction, but here the defects are quite large, and that's why the chances of intestinal obstruction are not so high as compared to inguinal or femoral hernias. Congenital inguinal hernias are at risk of intestinal obstruction in children. And that's why when a child with congenital hernia, inguinal hernia is seen, the parents should be advised surgery as soon as possible because of the high risk of intestinal obstruction and further complications. Volvulus, sigmoid volvulus accounts for almost 65 to 75% of cases amongst the volvulus seen in elderly patients with a chronic constipation. Here, the pathology is the abnormally long or a mobile sigmoid mesentery. So, if there is an abnormally long or a mobile sigmoid mesentery, on top of that, the sigmoid colon is also overloaded with stools in a chronically constipated patient. So it can easily rotate on its long axis along the mesentery and cause volvulus. Classically, a coffee bean sign or a bent inner tube on abdominal x-ray is a typical finding, and the treatment always remains a sigmoidoscopic decompression, which is the first line of treatment. If it fails, then only the open surgery should be preferred. Now, cecal volvulus is not so common, just accounts for about 20 to 30% of cases of total volvulus, but it is more common in young adults with a mobile cecum. And again, here, coffee bean sign may be seen. This requires surgical treatment in the form of fixation or resection. So these are the different types of volvulus which can be encountered. If you see the right three ones, the midgut volvulus, the cecal volvulus, and lastly the sigmoid volvulus, where there's a rotation of the bowel along its long mesentery, almost 180 degrees. Now coming to pathophysiology of intestinal obstruction, because understanding the pathophysiology would help you in managing your patient much better. So, just in nutshell, what exactly occurs whenever there is a mechanical obstruction to a segment of the bowel in the lumen or in the wall or outside the wall, the bowel contents would accumulate proximal to the obstruction. This would lead to increased intraluminal pressure proximal to the obstruction. This increased intraluminal pressure would affect the bowel wall. This would lead to, because the veins are thin walled, the first thing which would be compromised because of this increased intraluminal tension is venous outflow is impaired. When the venous outflow is impaired, there is a mucosal congestion leading to mucosal edema. And this mucosal edema would ultimately lead to capillary ischemia. And then it would lead to arterial inflow also gets compromised, and the bowel gets threatened by ischemic necrosis. Bacterial translocation is another very, very important cause of complication complications of intestinal obstruction. Because of mucosal edema and ischemic necrosis of the mucosa of the bowel wall, the mucosal barrier failure occurs. This leads to gram-negative bacteria, which are normally present within the bowel lumen, to translocate across the defective mucosal barrier through the lymphatics and portal circulation and going into systemic circulation and causing sepsis. So this is another important cause which can lead to the bacterial translocation leading to complications. There is also proximal to the bowel, there is a gas and fluid accumulation, swallowed air, bacterial fermentation producing gaseous distension, and there may also be outpouring of 7 to 8 liters of fluid which is secreted by the gut mucosa into the lumen. So the end result is that proximal to the obstruction, there is a massive accumulation of gas and fluid proximal to the obstruction. And because the patient has third space loss, this would lead to, and as well as vomiting, patient would go into hypovolemic shock, hypokalemia, and metabolic alkalosis. This is specifically seen in small bowel obstruction than large bowel obstruction. So this third space loss leading to hypovolemia and electrolyte imbalances like hypokalemia is also one of the ways in which the complications of intestinal obstruction is magnified or multiplied. Strangulation, we have already seen, is one of the real dangers of untreated intestinal obstruction. This would occur when the intraluminal pressure becomes so high that it would compromise the arterial inflow. And this leads to ischemia, infarction of the bowel wall, leading to perforation and ultimately perforation, peritonitis, and sepsis. So this in nutshell is the pathophysiology of a case of intestinal obstruction. So this slide would demonstrate to you what are the fluid and electrolyte disturbances which can occur. If you see specifically in the small bowel, the fluid loss is quite significant in small bowel because of third space loss and vomiting. Hyponatremia and hypokalemia again would occur because of this third space loss. Chlorides are also lost. Patient would go into metabolic alkalosis, and there is a hemoconcentration. Whereas in large bowel, the fluid loss is less as compared to small bowel. The sodium and potassium loss is also less as compared to large bowel. It depends on the type and the degree of obstruction. The chloride loss and even the metabolic disturbances are not so pronounced like in small gut. And hematocrit again may or may not rise, and generally reflects the dehydration severity. So there's a quite a distinct fluid and electrolyte disturbances which occur in a patient with small bowel obstruction as compared to a large bowel obstruction. Now, what exactly is a closed loop obstruction? We have already heard of this term in my previous slide, which I was talking about. What is a closed loop obstruction? When a segment of bowel gets obstructed at 2 points, 2 different points simultaneously. For example, a volvulus or adhesion band. A very classical example is that there is a competent ileocecal valve on the right side, and there is a completely occluding obstruction of the descending colon or sigmoid colon, say malignancy. So the bowel is, this bowel loop between the right and the left side, between these two obstruction is completely closed, and this is becomes a closed loop. So in this closed loop bowel, the intraluminal pressure rises quite rapidly, and this can lead to the complications which we have just seen, leading to perforation, ischemic necrosis, and other complications. So this closed loop obstruction is a surgical emergency and should be treated as early as possible because there's a high risk of perforation and peritonitis. This is an emergency. It should not be delayed whenever the closed loop obstruction is diagnosed. Now we'll come to the clinical features. Basically, we'll be dealing about the history, the examination of the abdomen, and how to differentiate between a small bowel and a large bowel obstruction. Clinical features typically are the four typical symptoms and signs. One is abdominal pain. The typical pain described by the patient is a colicky, central, intermittent pain which occurs every 4 to 5 minutes. This is the initial part of the obstruction where the bowel tries to overcome the obstruction by increasing the force and the frequency of peristalsis. However, over a period of time, the bowel gets tired, so called, and this would lead to the bowel sounds getting slightly sluggish. If the character of the pain changes from colicky pain to constant pain, which becomes diffuse, then this is not a good sign. This means that the bowel is at a danger of undergoing strangulation and ischemic necrosis. The severity of the obstruction do not correlate with the level of the pain. That's very, very important. Okay. Now, second important thing is clinical feature is vomiting, which is quite frequent and early in a proximal small bowel obstruction and quite late in large bowel obstruction or distal small bowel obstruction. Feculent vomiting is a very late sign, generally seen in large bowel obstruction. Abdominal distension may occur centrally in small bowel obstruction, whereas it may be slightly peripheral in large bowel obstruction. Abdominal distension is very minimal and very late in proximal small bowel obstruction, but it is very pronounced and early in a distal large bowel obstruction. And this abdominal distension may progressively worsens over time. It can also lead to splinting of diaphragm and respiratory compromise. And of course, the patient has constipation or obstipation. Obstipation is absolute constipation. That means no stools and flatus is passed, which would signify a complete intestinal obstruction. Partial obstruction may have some diarrhea initially. Mind you, this diarrhea is not true diarrhea, but it is what is called as spurious diarrhea, which is classically seen in a case of, say, a colorectal carcinoma with partial obstruction, where the bowel proximal to the obstruction leads to outpouring of fluid which can be passed down distally, and patient may interpret that as a loose stools, though in effect it's not a true diarrhea but a spurious diarrhea. There are general and vital signs also like tachycardia, which can lead to occur because of dehydration or sepsis. Hypotension may occur because of severe hypovolemic shock, which we have already seen. If there is a presence of fever in a case of intestinal obstruction, that's not a good sign. Any fever more than 38.5 degrees centigrade would suggest either a strangulation or a peritonitis. So, a fever is not a good sign in intestinal obstruction. Tachypnea may occur again because of a massive distension leading to splinting of diaphragm. It can also occur because of metabolic acidosis. And of course, there will be signs of dehydration like dry mucous membranes, reduced skin turgor, sunken eyes. If you examine the abdomen in a patient of intestinal obstruction, there may be distension of the abdomen, and sometimes visible peristalsis, especially in thin patients, can be seen. Look for any scars which would tell you the cause of intestinal obstruction as post-op adhesions. Surgical scars are always actively looked for in a patient when you're examining the patient's abdomen. When you auscultate, high pitched tinkling sounds characteristically are seen in early cases of intestinal obstruction. But over a period of time, these high pitched tinkling sounds may get slightly less and less, what we call the sluggish bowel sounds, and ultimately, towards the end, in a late stages, the bowel sounds may be totally absent, which is a late stage also signifies as peritonitis. So, any absent bowel sound in a patient of intestinal obstruction is a very, very sinister sign, and it suggests that there is a ischemic necrosis or even a peritonitis in that patient. When you palpate, there may be diffuse tenderness. If it is elicited, it could exhibit peritonism, and that would be a sign of strangulation or even peritonitis. If you percuss the patient's abdomen, then obviously a tympanic, because of gaseous distension of bowel, would be elicited. A digital rectal examination done in a patient would reveal empty rectum, okay, and hernial orifices must always be examined to rule out specifically the inguinal, the femoral, and the external genitalia and the paraumbilical area to rule out any hernias as a cause of intestinal obstruction. So this would be a clinical comparison of a small bowel and large bowel obstruction. If you see small bowel obstruction, we have seen commonest causes adhesions and hernias. Large bowel, it is carcinomas and volvulus and diverticular disease. Pain type in small bowel obstruction is colicky and central. Large bowel obstruction is more more commonly it's in the lower abdomen and slightly less intense. Vomiting is early, profuse, maybe bilious in small bowel obstruction, whereas vomiting is late feature or absent in large bowel obstruction. Distension of the abdomen would be central and early, late feature in a small bowel obstruction, whereas a large bowel obstruction, the distension is quite marked and peripheral, especially in distal large bowel obstruction. Constipation is a late feature in small bowel obstruction, whereas early and a prominent symptom in large bowel obstruction. Onset of small bowel obstruction is often acute, whereas large gut obstruction is more subacute or insidious. The electrolyte abnormalities like hypokalemia or hypovolemia or metabolic alkalosis are quite prominent in small bowel as compared to large bowel obstruction, where it is variable and depends on severity. If you see the X-ray abdomen, which we'll see in detail subsequently, you would see a dilated small bowel more than 3 centimeters with presence of valvulae conventus, whereas in a large bowel we have dilated colon more than 6 centimeters with haustral markings. The risk of perforation in small bowel is less, whereas in large bowel it is slightly more than small bowel. So these are the clinical ways in which you can differentiate between small gut and large gut. Now we'll go on to investigations and management. So first, the blood test should be done. Full blood count, if there are increased leukocytes, would suggest infection and strangulation. Hematocrit may be raised, which would tell you the degree of dehydration because of third space loss. If the patient is anemic, it could be because of underlying malignancy, which is a cause of intestinal obstruction. If you do a arterial blood gas analysis and serum lactate, metabolic alkalosis we have already seen would be a feature in early small bowel obstruction. And increased lactate level more than 2 millimoles per liter would suggest the patient is going into sepsis, and this is one of the signs for urgent surgical intervention. C-reactive proteins more than 100 would suggest significant inflammation, and serial C-reactive proteins and procalcitonin can be used to track the progress of the patient. Urine examination, which would tell you increased urea and creatinine, especially in the cases of hypovolemia, would be a precursor sign for kidneys being at the risk of hypovolemic damage, pre-renal acute kidney injury. Hypokalemia may be seen, we have already seen that, where the serum potassium may go below 3.5 millimoles per liter. Hyponatremia may also be a feature in small bowel obstruction. Raised amylase sometimes may be seen in chest obstruction, which may mimic pancreatitis. Liver function test should be done, and coagulation profile is very important. Patient may be requiring blood transfusion, so blood grouping cross matching should be done in such cases. Plain abdominal X-ray plays a very important role and one of the initial investigations of imaging to be done in cases of small bowel and large bowel obstruction. What are the typical findings of small bowel and large bowel? We would see on this slide. When you see an abdominal X-ray in a case of small bowel obstruction, if you see centrally dilated bowel loops, which are more than 3 centimeters in diameter, then that probably is a small bowel. When you see valvulae, which we'll see in subsequent slide, which are the thin mucosal folds, which covers entire circumference of the gut, this is typically seen in jejunum, small bowel, jejunal loops. Step ladder pattern, which basically suggests multiple air fluid levels at different heights are seen on erect abdominal X-ray. Colonic gas may be less or absent in cases of small bowel obstruction, especially complete obstruction. And if there is any pneumoperitoneum, free air with a gas under the diaphragm, that obviously would suggest that there is a perforation of the small bowel. Whereas abdominal X-ray and large bowel would be more peripherally dilated gas-filled bowel loops. Here, hostrations would be seen. Now, the difference between a valvulae, which is seen in a jejunum, and hostrations is that valvulae do not cross the entire circumference of the gut. They are incomplete. Whereas the valvulae covers the entire circumference of the bowel wall. Whenever in a large bowel obstruction, cecal diameter goes beyond 9 centimeters, the risk of cecal perforation is quite high. This is Lars's law. Coffee bean sign we have already seen is typically seen in sigmoid or cecal volvulus, and any lack of rectal gas in a complete large bowel obstruction would suggest a complete obstruction, a lack of rectal gas. So we'll see the x-rays now and see how it looks like, what the points which we have just discussed. Now this is a typical step ladder pattern where you can see multiple air fluid levels, especially in a case of small gut obstruction, as the bowel, most of the bowel is seen centrally. Now here it shows the a small bowel obstruction. Typically, the points which we have just discussed, here you can see valvulae conniventis. The valvulae conniventis, as shown on this X-ray, are the mucosal folds which covers the entire circumference of the bowel wall. And also, if you see, they are symmetrically placed. So because of their completeness and their symmetry, the bowel, these are the jejunal loops. This gives the typical appearance of a coiled spring appearance or stack of coins appearance. And when you see such type of bowel which are centrally placed with valvulae conniventis giving that coiled spring or stack of coins appearance, then classically this is a small bowel obstruction. Now the bowel diameter is also dilated. So just remember the rule 369, rule of 369. Any small bowel more than 3 centimeters in diameter, any large bowel more than 6 centimeters in diameter, and any cecal diameter more than 9 centimeter in diameter suggests that the bowel is dilated and some form of obstruction is always present. Now this is a typical large gut. You can see the bowel is placed peripherally and the hostra are seen. Now, if you compare it with the previous X-ray where the valvulae were complete and symmetrical, the hostras are incomplete and asymmetrical. That's how you differentiate between a hostration and a valvulae conniventis. This is a typical coffee bean sign, which is seen in a patient of either a sigmoid volvulus or a cecal volvulus. Because sigmoid volvulus is so common, here it is seen in a case of sigmoid volvulus, the coffee bean sign. CT abdomen and pelvis remains one of the gold standard investigations with IV contrast, one of the gold standard investigations for a case of intestinal obstruction. It has got almost a 96% specificity, sensitivity, and 95% specificity for complete obstruction. It clearly identifies the site of obstruction as well as cause of obstruction. It would also tell you whether there is any closed loop obstruction or not. It would also give you the signs of strangulation or ischemia. For example, the presence of gas in the bowel wall, what we call pneumatosis intestinalis. That means if the gas is seen within the wall of the bowel gut, then that is a sign of ischemic necrosis or strangulation. The second common sign which suggests ischemia is presence of portal venous gas. Edema of the mesentery is not a good sign on CT scan, and that suggests possibly ischemic necrosis of the gut. And fat stranding. These are the typical signs of strangulation on CT scan with contrast in a patient of intestinal obstruction. Pneumoperitoneum or free gas means obviously that there is a perforation of the bowel wall leading to pneumoperitoneum. So this becomes a surgical emergency. Sometimes oral contrast may be used, which is a gastrographin, which can be diagnostic and therapeutic in cases of partial a small bowel obstruction. So just to recapitulate the CT signs of strangulation: the bowel wall thickening more than 3 mm, presence of gas within the bowel wall, that is pneumatosis intestinalis, presence of portal venous gas is a very ominous sign and seen in strangulation. Any edema of the mesentery or fat stranding of the mesentery is another sign of ischemic necrosis. Absence of bowel wall enhancement on CT is another important sign suggesting of necrosis. Presence of ascites, which may be reactive or due to peritonitis. So, any presence of free fluid within the peritoneal cavity may suggest perforation. And obviously, pneumoperitoneum or free air in the peritoneum is not a good sign in intestinal obstruction. This would suggest a perforation of the bowel wall. So this is a typical CT scan which is seen on the left side is normal, and the right side you can see obstructed bowel with air fluid levels. Now, this is a whirl sign which is seen in cases of intestinal obstruction, especially because of malrotation of volvulus of the either a midgut or a sigmoid colon. Okay, so this whirl sign is normally seen in cases of a rotation of the gut or volvulus around its long axis. This is a classical whirl sign or whirlpool sign, which is also known. Now we'll come on to the management. First, we'll talk about initial resuscitation, a trial of conservative measures in which patient to be given, and then endoscopic and surgical managements. The initial management is the assessment of the patient and resuscitation, which take priority over the definitive management. Most of the time, when the patient comes to the emergency department or admitted to the ward, these patients may have hypovolemia, they may have fluid and electrolyte disturbances, they may have other comorbid conditions. So, the general assessment and resuscitation takes priority before we go on to do a definitive procedure. So, first is the airway protect, especially in a patient with reduced GS because of vomiting risk. Nasogastric tube insertion reduces the aspiration risk, and also if the abdomen is massively distended, nasogastric tube should be inserted to drain. This not only reduces the girth of the abdomen but also prevents the splinting of the diaphragm. It also promotes peristalsis and it also obviously prevents the risk of aspiration. Breathing, give oxygen supplementation if the saturation is less than 94% on room air. And many of these patients we have already seen are respiratorily compromised because of abdominal splinting. Circulation, secure 2 large IV bore cannula access, 16 to 18 size. Start IV fluid, especially Ringer's lactate Hartmann solution or normal saline. Target a heart rate of less than 100. Mean arterial pressure of more than 65 millimeter of mercury, and urine output of at least 0.5 ml per kg per hour. Look for any disability, rule out blood glucose, hypoglycemia, check for any Glasgow coma scale. If the patient is having pain, record the pain score and give adequate analgesia if the pain is quite intense. Monitoring of the patient is very important. A strict intake output chart should be maintained to know the fluid balance. Nasogastric tube decompression plus output of the nasogastric tube should also be monitored. Patient should be monitored on a 12-lead continuous ECG. Patient should be on a continuous SpO2 monitor, and serial arterial blood gas analysis should be done in such patient. Once the patient has become slightly stabilized with these maneuvers, you can simultaneously take investigations, blood investigations like full blood count, urine examination, liver function test, complete coagulation profile, arterial blood gas analysis, and serum lactate levels. When the patient is stable enough to go to an X-ray radiology suite, do an abdominal X-ray erect. If the patient is unable to stand, then do a supine X-ray in a left lateral decubitus position. CT abdomen and pelvis with contrast IV should be done only when the patient is stable enough. And based on your findings, do a immediate definitive management. So this protocol is basically to stabilize the patient before we go on to do a more definitive process. Now, the word comes whether to do a conservative or non-operative management or operative. So the typical conservative management is known by the regimen of drip and suck. And what are the indications? The indications of conservative management is in a patient whom you suspect as a case of partial small bowel obstruction or a post-operative small bowel obstruction which occurs within 6 weeks of surgery, because most of the time the adhesions are fibrinous adhesions in such cases such early. So you can do a drip and suck method of conservative management in such cases. Any patients with known Crohn's disease with partial obstruction can undergo conservative management. Small bowel obstruction in a virgin abdomen, that means a patient who has not undergone any previous surgery, who comes to you with a partial small bowel obstruction, you can give a trial of conservative management for at least 24 to 48 hours. Any patients who are at high risk of surgery, like patients with severe cardiorespiratory comorbid conditions, where the outcome of surgery may not be so optimal, in such cases, you can give a trial of conservative management. Sometimes a patient preference after informed consent would also make you give a trial of conservative management. Now, what are the indications of surgery or surgical intervention when it should be done? The commonest indication of surgery is a complete small gut or a large gut obstruction. Now, because we have already seen that whenever there is a complete obstruction of the bowel, the events are dramatic. The presentation is quite intense and acute. The symptoms are also quite severe. These patients are at risk of complications quite quickly, and that's why this becomes the number one indication, a complete small bowel or a large bowel obstruction. Any patients who has signs of strangulation in the form of silent abdomen, diffuse abdominal tenderness, rebound tenderness, presence of ascites, would tachycardia, fever, such cases should undergo immediate surgery rather than a conservative management. Any closed loop obstruction seen on CT scan would be an immediate indication for surgery, because we have already seen that such patients are at risk of undergoing complications quite quickly. Any signs of peritonitis in the form of free air under the diaphragm, or ascites, or signs of peritonism is an indication for surgery. Any failure of conservative management trial given for at least 48 to 72 hours and no relief on conservative management would be an indication for surgery. Very important indication. All patients with volvulus, which cannot be reduced by endoscopic measures, should undergo surgery. Hernia leading to obstruction or incarceration would be an indication for surgery. Perforation, we have already seen with pneumoperitoneum, would be an indication of surgery. And even before 48 to 72 hours, if you have put a patient on conservative management, and even say in 24 hours only the patient starts to deteriorate rapidly, then don't wait for 48 or 72 hours. The patient's condition would dictate your decision whether to operate or not. So even in the first 12 hours or 24 hours of conservative management, if your patient rapidly deteriorates in the form of increasing distension, increasing vomiting, presence of sepsis, don't delay, abandon the conservative management and immediately put the patient on surgical surgery and operate immediately to prevent further mortality. What are the different operative procedures? Because adhesions plays a very important cause of intestinal obstruction. So the commonest surgery which is done for adhesions is adhesinolysis or adhesiolysis. It basically means division of adhesive bands by sharp dissection, which can be done both by open or laparoscopic way. And the rule of three would dictate the surgeon whether to operate or not in a patient of adhesions. If three closely matted loops are seen, then open up the patient. That means operate. Three closely matted loops. If the cause of obstruction is hernia, then immediate reduction after opening the sac, ascertaining the viability of the contents, and then doing a repair with a mesh plus or minus depending on condition of the patient. Tension-free mesh repair should be done. If the viability of the gut is compromised, that means there's a frank gangrene, then resection of that segment of bowel should be undertaken. Bowel resection and anastomosis is not a preferred surgery any surgeon would like to do. But if the obstruction is not relieved immediately, the patient undergoes ischemic necrosis and there is obvious strangulation and necrotic bowel or a tumor involved bowel, then in such cases you have to resect that segment of the butt which is unhealthy, which is pathological, and then you can take a decision whether to do a primary anastomosis if there is no contamination and patient is stable, or you can create a stoma and do surgery at a later stage where there is a restoration. Hartmann's procedure would be done in such cases, sometimes where there is a perforation of the bowel with peritonitis, and in such cases we can do a resection with the end proximal colostomy and closure of distal rectal stump. Generally seen, you can do this procedure in perforated bowel with contaminated peritoneal cavity in an elderly frail patient. And then you can plan for reversal of bowel continuity after 3 to 6 months of Hartmann's procedure. All volvulus cases would require immediate detorsion or sigmoidectomy, depending on how much is the viability of the bowel. Emergency decompression with or without sigmoidectomy should be done to prevent recurrence. 50% you can do, most of the cases, endoscopic decompression, which is the preferred initial treatment for any volvulus. This is the Hartmann's procedure which I was talking. You can easily do this procedure, quite important damage control surgery procedure, especially in a perforation of the bowel because of intestinal obstruction, where you excise a part of the bowel after ligating the mesenteric vessels. The proximal descending colon is brought out as a stoma and colostomy, and the distal rectum is oversewn with staples as a rectal stump. And later, once the patient can undergo, after 3 to 6 months, restoration of bowel continuity. Specific strategies may be done in large bowel obstruction, like colonic stenting. Stents can be used, especially in cases of malignant large bowel obstruction, and where the patient is unable to undergo surgery, or patient is on a palliative care, or it can also be as a bridge to elective surgery. Colonic self-expanding metal stents. The advantage of using these stents is that it avoids immediate emergency surgery in a patient who may not be hemodynamically stable, and success rate is more than 90%. But of course, it is contraindicated in a patient of peritonitis or perforation. Hartmann's procedure we have already done, which is emergency procedure where there is a resection and colostomy, which can be done in the patients of large bowel obstruction with peritonitis because of perforation. Sometimes on-table lavage with primary anastomosis is another modality which can be used, where during surgery, once the gut is opened, intraoperative colonic washout can be done, and then this allows the primary anastomosis once you resect the bowel. This basically avoids stoma if this procedure is done, but of course it would increase the operative time. On-table lavage with primary anastomosis. In sigmoid and cecal volvulus, the first step to do is a flexible sigmoidoscopic decompression, which is the first line of treatment. But the recurrence rate is 50% without any elective sigmoidectomy. And in cecal volvulus, surgery only is the option. Here, the endoscopic option is quite limited, and many of these patients would undergo either a right hemicolectomy or a cecopexy. Laparoscopic approach is much better than open approach, especially in the patients who are hemodynamically stable. What are the complications and outcomes of a patient with intestinal obstruction? Strangulation and gangrene is a very distinct possibility we have already seen, which can occur in 25 to 40% of patients of small bowel obstruction if it is left untreated. And irreversible ischemia of the bowel wall would occur within 6 hours 6 hours of any compromised arterial flow. And if there is a irreversible ischemic damage, then this would require resection of that segment of the bowel, which itself would increase the mortality to more than 25 to 30%. Perforation of the gut leading to peritonitis is again a very important complication which can occur. Cecum is the most vulnerable part of the gut, especially in a closed loop obstruction. This can lead to fecal peritonitis and, of course, sepsis. Mortality increases to almost 50% with fecal contamination of peritoneal cavity. Short bowel syndrome. If there is an extensive resection where more than 70% of small bowel is excised because of ischemic necrosis, then this would lead to what is known as short bowel syndrome, where there would be malabsorption, diarrhea, and different types of nutritional deficiencies. And such patient may require long-term total parenteral nutrition or even an intestinal transplant. Post-op ileus, a prolonged post-op ileus may be also one of the complications. And this basically could be because of so many factors. If there's a prolonged post-op ileus, like sepsis, or it could be because of electrolyte disturbances like hypokalemia. Reobstruction is always a danger, especially in patients of adhesions. Additional small bowel obstruction occurs in 10 to 30% of, so 30% of cases following adhesiolysis are at risk of reobstruction. When exactly this would occur is difficult to predict, but you must make sure that the initial warning signs are picked up in cases of recurrent intestinal obstruction. And a recurrent intestinal obstruction is an indication for surgery. Laparoscopic approach always reduces the chances of recurrence because of less adhesion formation. The mortality, if you see long-term outcome, simple obstruction, where there are no complications, the mortality is about 2 to 8%. But if it goes into strangulation, then the mortality rises to about 15 to 25%. And if there's a perforation, especially in a large bowel, then the mortality can go more than 30 to 50%. The mortality always increases with increasing age. Any delay in the surgery or any associated comorbid conditions, especially if they are also not optimized. So, to sum it up, small bowel obstruction, commonest cause is adhesions. Large bowel obstruction, commonest cause are colorectal carcinoma. Always examine hernial orifices. ABC resuscitation is first, IV fluids, nasogastric tube, analgesia before any imaging. CT abdomen pelvis with eye contrast is the gold standard investigation, which would identify the cause, the site, as well as signs of strangulation. The strangulation sites typically on CT are increasing lactate, is not on CT, but biochemically would be increasing lactate, fever, signs of peritonism, portal gas on CT scan, pneumatosis intestinalis on CT scan. All these are signs of strangulation, which would indicate immediate surgery. Don't delay. Large bowel obstruction with a competent ileocecal valve would classically lead to a closed loop obstruction where the cecum is at risk of perforation, especially if the cecal diameter is more than 9 centimeters. The surgical timing matters in a cases of intestinal obstruction. Any delay of more than 6 hours, especially in a case of strangulation, would double it to almost 50%. Operate early when in doubt. This is the best dictum for anyone who is dealing with such a patient. Whenever there is a doubt about intestinal obstruction, always operate, open up the abdomen, and try to relieve the obstruction rather than continuing a conservative management. With that, I come to the end of this presentation. If you have liked this very, very important topic, which I have discussed in great detail, then please subscribe to my channel. I would keep on coming with such more and more topics which would help all my students as well as PG residents to face such important surgical cases. Thank you for watching and your time.